All right, hello and welcome. Today, we're tackling one of the biggest challenges in surgery, infected necrotizing pancreatitis. And we're going to break down a technique that has fundamentally changed the game, videoscopic assisted retroperitoneal debridement, or VARD.
So here's our game plan. We'll start by framing the problem, then we'll dig into the critical shift in timing our interventions. We're going to walk through the VARD technique itself, see how it stacks up against other methods, and finally, we'll put it all into historical context.
Okay, let's get right into it. To really understand why VARD is such an innovation, you first have to appreciate the incredibly high-stakes problem it was designed to solve.
For surgeons, this has been the nagging, central question for decades. When you're faced with a critically ill patient with infected pancreatic necrosis, the path forward has never been simple, and you know the consequences of our choices are just massive.
And here is exactly what's at stake, in black and white. For years, the standard was an open necrosectomy via laparotomy. But look at the staggering cost, a mortality rate between 15 and 27%. That number, all by itself, is why the hunt for a better way became so urgent.
You see, the core problem wasn't just about getting access to the necrosis. It was the immense physiological stress of a major laparotomy on a patient who is already in septic shock, already fighting multi-organ failure. The traditional approach was often just more than the body could handle, and that directly fueled the search for minimally invasive alternatives.
This brings us to one of the most significant paradigm shifts in treating this disease. It's not just about how we operate, it's about when.
The key concept here is demarcation. This is the body's natural process of walling off the dead tissue from the healthy, living tissue around it. This process creates a more mature, defined collection that's much safer and easier to surgically debride. It turns a diffuse inflammatory mess into a distinct surgical target.
So what does this mean in practice? It means we wait. The evidence overwhelmingly points to delaying intervention for at least 4 weeks from the onset of symptoms. This waiting period allows that critical process of demarcation to complete, which dramatically improves the conditions for a successful and safer debridement.
All right, so now that we've established the why and the when, let's get to the how. We're going to walk through the elegant VARD technique step by step.
It starts with a percutaneously placed drain, which not only provides initial drainage, but also acts as our roadmap. Following that guide, a small 5-centimeter incision is made to enter the retroperitoneum. Initial debridement is done under direct vision. Then, and this is the key, a videoscope is introduced. This allows for precise, visually guided removal of deeper necrotic tissue. The procedure wraps up with a thorough irrigation and the placement of large bore drains for post-op lavage.
And this illustrates another fundamental shift in philosophy. With VARD, the objective is not a radical, complete necrosectomy on the first go. Instead, the focus is on source control, getting the bulk of the infected, loose material out while minimizing the risk of injuring underlying vessels. It prioritizes patient safety over an aggressive and potentially dangerous debridement.
So where does VARD fit into the surgical arsenal? To really understand its value, we need to compare it to the approaches that came before it.
Let's just break down the alternatives. Open laparotomy was simply too invasive. The open translumbar approach, while retroperitoneal, was relatively blind and came with high complication rates. And the purely endoscopic techniques often required multiple, time-consuming procedures. VARD just sits right in that sweet spot, combining a small incision with excellent visualization.
So let's just sum up the key advantages. With VARD, you get a much smaller incision than the old open retroperitoneal approach. We can remove larger chunks of necrosis than with pure endoscopy, which means fewer repeat procedures and shorter operative times. And most importantly, that videoscope adds a critical layer of safety, reducing the complications that plagued earlier blind techniques.
Finally, let's place this technique in its proper context. VARD didn't just appear out of nowhere. It's standing on the shoulders of giants and is the product of decades of surgical evolution and refinement.
You can see the progression so clearly here. In '89, Finges pioneers the direct retroperitoneal approach. A decade later, Carter introduces endoscopic debridement through a drain tract. Then, just 1 year after that, Horvath combines these ideas in the first VARD series. And by 2006, landmark trials like PANTHER begin to formally validate this step-up approach. It's a beautiful story of iterative innovation.
The authors of our source paper just summarize it perfectly.
They describe VARD as a hybrid that contains the best of both worlds, the direct access of an open approach with the precision and minimal invasiveness of an endoscopic one.
And that brings us to our main takeaway. VARD is a relatively simple, elegant, and effective technique. In the right hands, it's applicable to most patients with infected pancreatic necrosis and represents a far superior alternative to the high-risk laparotomy of the past.
And that leaves us with a final thought. As more data from large randomized trials comes in, the role of VARD and other minimally invasive step-up approaches continues to solidify. The question now isn't whether it's better than open surgery, but whether it will become the undisputed standard of care. Thanks for joining us.